Good morning, everyone, and welcome to Denver Museum of Nature and Science at Home. We're so excited to be having you joining us here for our COVID webinar series. I'm Kristen Uhlenbrock, and I work at the Institute for Science and Policy, a project here at the Denver Museum of Nature and Science. I also want to recognize and thank our lovely partners from the Colorado School of Public Health who've been helping us put together this series. We're actually quite excited to have the Dean joining us today, Jonathan Samet. Before we get started, I do just want to take a moment to say welcome to everyone and how grateful I am that you have been participating with us as a really engaged and thoughtful audience all along. If you've been here from the very beginning and have been counting, this is going to be episode 12. I would love to see in the chat if we've had any sort of folks who've been here for all 12 episodes. That is some true loyalty and we're very appreciative for you. If this is your first time joining, we're so excited that you found us. Welcome. This series is really about bringing you science and stories as it relates to COVID-19. I also want to say before we get started about how challenging of a time this pandemic has been. It really is unprecedented. People are sick, people are losing family members, people are losing jobs. Our way of life has been flipped upside down. We know how extremely stressful this is. We know that we're all trying to cope and manage in our own ways. And we really hope that this series is bringing you just a moment where we can learn together. We really value science and we value how science can be used to make really difficult decisions. Decisions that will hopefully make us a little bit better, a little bit more resilient, and a little bit more prepared as a society. So we like to say that our value at the museum is that we think critically and act with empathy. And we hope that you do too. So a few housekeeping items. For those of you who are quite familiar and joining us here on Zoom, welcome. You can open up that chat if you haven't already, shared where you're tuning in from, and that's going to be right where you drop in your questions. If you're joining us on Facebook Live, you go ahead and use that comment feature on Facebook Live to ask us questions. Just so you know, we see and read all of your questions. We are so thankful for them. We get so many that we definitely cannot answer all of them. We do try to do our best to answer some that are really relevant to our panelists, but they also help us think through how to think about future episodes. So even knowing if your question doesn't get answered, that we do read it and we do value it. So thank you for being in a very engaged audience all along. So today's episode is a midsummer update. I don't know where the time has gone, but apparently we're smack in the middle of midsummer right now, and also 5 months into trying to manage this pandemic. If you've been closely monitoring like I have, you've been seeing a resurgence of COVID-19 happening around the country with a lot of new hotspots peaking up everywhere. We're also seeing a rise in COVID cases here in Colorado as well. It's summer, people are out and about, people are starting to travel more. People are going to the mountains here in Colorado. We're seeing tourist increases that just comes with summer. But what that means is, of course, that the spread of COVID-19 is seeing this more too. And so we're going to see a little bit about the latest data and modeling results, as well as kind of hearing from speakers who are working in those counties that are not here in the Denver metro area. So I'm really excited to have 3 guests joining me today and very honored for their time. Our first guest is our dear friend and partner, the Dean of the Colorado School of Public Health, Dr. Jonathan Samet. Dr. Samet is a pulmonary physician and epidemiologist and serves as a professor within the school. He's been spearheading our modeling here in the state of Colorado, and he's going to provide us with an update this morning. Our other 2 guests today is Karen Koenemann, who's been the public health director for Pitkin County since 2017. Previous to that, she served as the Delta County public health director, and before that, the healthy communities manager for Eagle County Public Health and Environment. She served as co-chair of the Colorado Health Equity Commission and currently serves on the National Association of County and City Health Officials and the West Mountain Regional Health Alliance. We're excited to have Karen joining us from Pitkin County today. And our third guest is John Douglas. He is the Executive Director of Tri-County Health Department, which represents Adams, Arapahoe, and Douglas County right now. Prior to Tri-County, John was the Director of the Division of STD Prevention at the Centers for Disease Control and Chief Medical Officer at the National Center for HIV, AIDS, Viral Hepatitis, STD, and TB Prevention, that is a long name for that division, supervising over 300 public health professionals in both domestic programs and international efforts. Prior to that, John was the director of STD control at Denver Public Health, an attending physician at Denver General Hospital, and professor of medicine and preventative medicine at the University of Colorado School of Medicine. So we have three wonderful experts joining us today. So I don't want to take up any more of the time. Let me turn this over and welcome Jonathan Samet. Good morning, John. How are you?
Good morning, Kristen, and ready to get started. And I'm pleased to see that we have some folks who have been through all of the sessions. I guess that includes yourself and me as well. So with that, let me get started. What I'm going to do is sort of a preamble to the conversation with Karen and John, is to just give an overview of where we are. I think everybody knows that things have been changing over time, and I'm just going to give you a quick look at some of those changes, and that will set us up for our discussion. So I have to say that we have a really cute graphic for today that I borrowed. So let me just say a little bit. So one of the measures that we've been tracking is time at home as a measure of mobility. And this picture just shows time at home in the Denver metro area and the rest of Colorado. And you can see that in March, as things closed down and then were closed down across April, we spent more time at home. And now we're more mobile. We're spending more time outside of our homes. One thing that we've learned is that mobility was a pretty good measure of how much we were mixing back in April and May, but now it's not quite as good because we're doing different things. We're going to stores, we're going to restaurants, we're going outside. And so things have changed a bit. Now, this is important, and certainly important for all our counties, but particularly communities that have a lot of summer tourist visitors like Pitkin County. This shows you last year, 2019, with that nice 4th of July peak of visitors. And this year, you can see we bottomed out, as you would expect, in April. And now visitors from out of state are rising. And part of the challenge for public health is that some of these folks are coming in from places that are hotspots, like Florida, like Texas, like California, Los Angeles, for example. And some of them may be coming in with infection. So things have changed over time. This epidemic is by no means static, and on the ground public health is continually needing to adapt to what is going on. Here's visitors to Denver County. This is about a week ago. And again, the red lines show folks coming in from hotspots. So these are based on cell phone data, and these are cell phones traveling into our state in the hands of people. And again, you can see that people are coming in from across the country and from areas that are currently hotspots. Now, just a quick overview of where we are. These are up-to-date data, and I think everybody knows that we're having rising numbers of cases in Colorado as elsewhere. Week over week, we had a 23% increase last week. Now, cases are a little bit complicated because how many cases we find in part depends on how much testing we're doing. So we are doing more testing, which will lead us to detect more cases, particularly among those who are asymptomatic. Now we have other indicators, and one is hospitalization, which our group tracks closely for the modeling. And if you look, we have people in the hospital for COVID-19, this big peak of 800, 900 people back in mid to early to mid-April, actually falling as low as about 126, 36, rising again in recent weeks, and now at a plateau. So we were concerned, and I'm going to show you some pictures, that things might be going up again as they have in some other states. We're on this plateau right now of hospitalizations, which we think is an important indicator. Deaths, down, and certainly nowhere near the peaks that we saw back in April. And again, an index we closely watch, but remember, one that lags. So if the epidemic starts to go up with cases, it takes a while for that to be reflected in increasing numbers of deaths. Now, the epidemic has changed over time, and this is really important to control, to the steps to be taken, and to where we think things might go. So Colorado, like other states, is having this surge of cases in young people. So here you can see this red line for 20 to 39-year-olds rising sharply. And I'm going to show you that the younger age range has now become the majority of the cases. We're seeing rises in 40 to 64-year-olds, sort of lagging behind, but leading right now are infections in younger people. And if we look at the age distribution of cases, that figure now for under 40 is up over 60% of the cases we're seeing, which again makes us think back, what's going on? And we'll have that in our discussion. Why are cases rising in this age range? Hospitalizations, we see the decline, the drop. Remember that our severe disease has been in those who are 60, 65 and older. 90+% of the deaths have been in people over 60, but we're seeing more hospitalizations now in younger people. And if we look at that proportion of COVID-19 hospitalizations under 40, it's tended up over time. Now, some of that's because we're having less in older people, but an important reminder here to those who are under 40 is that they do get symptomatic disease and that they can be sick enough to be in hospital, and some have died. Now, the epidemic, and this was the topic of the last two sessions, has hit different groups within our populations with different impact. This is the infections by race and ethnicity, and you can see early on the high counts among those who are Black and African American, and also among those who are Hispanic or Latino. The American Indian Alaska Native numbers bounce around a bit because there is a smaller population. And then when we look at hospitalizations, again, we see this disproportionate burden that we discussed at length in the last two sessions. And that's been such an unfortunate aspect of the pandemic across the country and across the world. I've said that pandemics thrive on inequality, and certainly this one has. So let me take you an update on the modeling. As Kristen mentioned, our team has been doing the infectious disease modeling in support of the CDPHE, our Colorado Department of Public Health and Environment, and the governor's office. Now, what do we do with the modeling? This takes me back to the very first session where I talked about our modeling and what we're doing. We look back and we say, what happened? We fit our models to the data and look at how the epidemic propagated. And then we use the values out of the model and say, well, what's going to happen? And I'm going to focus on what will happen. What are some of our scenarios look like for the near term and the longer term? Now, one output of our model is the so-called reproductive number. You've heard about this, talked about the R0 value. You heard that a lot from the governor back in March and April. The R or R0 value is the number of new cases per infected person. So if that number is above 1, an epidemic propagates. If it's below 1, the epidemic is not going to propagate because each case does not make more than one additional case. So you can see the number as we've calculated it over time, dropping below 1, staying well below 1 across April and May as we were shut down. And then in recent weeks, going back up and maybe coming down. It jumps around a little bit because of the way we calculate it. So the message out of this, and it's backed up by the case counts, is that our reproductive number went above 1, but we think over the last week or two, it has been above 1, but is coming down a bit. We look at this every week. We'll be looking at it today and tomorrow, and we're very interested to see where that number is. It's very important in terms of how well we're doing in reining in the epidemic. Now, I said we look and propagate that, use that number and say, well, what's going to happen? And so here's a short-term look at what we think might happen with hospitalizations and intensive care unit needs. Now, we've made some assumptions here. For example, that mask use is at 90%. Masks do work, a tool we need to use. We've been estimating 70%. We're hoping that with the new mask order and public education about masks, that figure will go up. Social distancing, you've heard that word a lot. We're referring here to infectious contacts that can lead to infection among people. And this figure, social distancing, calculates staying away from people, staying at home. It also incorporates things that reduce the likelihood of infection, so good hand hygiene, for example. So when we were doing really well and we were shut in, social distancing was, for example, an 80% reduction. In recent weeks, we think that we could have been down to 45%. More recently, we're calculating that we're about 52%. So what we're showing on these plots, and if you focus on the intensive care unit plot, you can see if we're at 45% social distancing, figure we thought we might have been at a couple of weeks ago, we go over our critical care capacity, our ICU capacity to take care of really ill patients. If we go to 52%, we'll get there eventually. If we stay at 55% or better, even 60%, 65%, we're doing well. And I show you these months in detail because, of course, we're facing school opening coming up, people returning to universities and other changes. Now, the next plot is going to show you a longer term picture. And here now you can see that without enough social distancing, we have these very high peaks, like the blue one here, where we exceed critical care capacity. And our problem is that if the virus is there, and most of us are not yet immune in any way, we're still probably 95% susceptible in Colorado, then the virus will find us and we'll have an epidemic peak unless we sustain our epidemic control measures that keep us socially distanced. So these are scenarios, for example, the blue one or the orange one, that we want to avoid. And our models tell us that these things could happen unless we maintain the needed degree of distancing. So in recent weeks, as I've said, it looks like we've flattened out. And so what I'm showing you is the trajectory that we would be on if we'd been at 41%, not a very good one, or where we think we are at 52% estimated last week. And you can see that our case counts, our hospitalizations, are actually going down. So we're seeing this plateau in hospitalizations. Things are bouncing around a little bit, but in general, we're looking better than we thought we were 2 weeks ago. And I'm going to give you some ideas, and we'll hear from John and Karen their thoughts about why this could be happening. Just a reminder, masks work. And I'm showing you on the left what happens with mask use at different points. There's a big difference between mask use at 70% and 90%. So things get smushed down. And again, I would just urge those of you out there who have skepticism about masks, or those who want to understand what they do make a difference. So what's happening? This is going to be part of our discussion. We've seen this rise in young people. We've had some events that may have figured in. We had large gatherings with protests. We had bars opened, and now closed, and now most recently, no alcohol served after 10 p.m. We've had summer visitors. Counties have had different variances in place when the evidence of epidemic control in the counties was sufficient. And we have the mask order. And then what is to come? The protect our neighbors phase, where counties with their local public health agencies can apply to allow certain things. We have school opening. We will wait to see the effect of the mask order. Fall will come, and when fall happens, of course, it will be colder and we'll return indoors, and influenza season. So there's lots to come, and lots that could change the face of the epidemic. So I'll just close. I did a press conference with the governor several weeks ago. This was the week before he gave the mask order. Here's his summary comment then about wearing masks. Science supports using them. Polis, our governor, wear a damn mask. So I'll close with that message. Thanks, and we'll move on to our discussion. Delighted that Karen and John could join us today.
Thank you, John, very much for the update and for all the work that you've been doing. I'm going to start actually with a question back to you, because we had a lot that come in through your thing, and then transition this over into Karen and John. So folks are often, we've seen you present both case data and the number of deaths. I'm wondering if you could talk about the value and the difference of looking at both of those data points. You know what I mean? And how do we use that as a decision-making, tool, looking at specifically at case data versus those at deaths? You briefly talked about ICU capacities, but just elaborate that a little bit more. And then we'll turn it over to Karen and John, where I want to hear from both of them a similar thing about case data versus those in your communities. Like how are you doing with previous case data and current case data, and where are you seeing peaks and rises? So let me start with John first, and then I'll turn this over to Karen.
I mean, I think, of course, the answer is there'll be different perspectives on this depending on what you're trying to accomplish. I mean, we've used the critical care threshold and hospitalization as a key metric because everyone wants to avoid running out of ICU beds. And so as a metric for modeling and for giving policy guidance, we have tried to assure that we don't hit that critical threshold, or to alert those involved at the state and local level if we're heading towards it, so that surge capacity could be augmented. Cases, I think, again, we'll hear from Karen and John, are going to be very useful for them for tracking what's going on at the county level. And of course, deaths we want to avoid. And when they're happening, we do need to know who is dying. Of course, a huge amount of the burden has been disproportionate. It's affected those in long-term care facility and specific populations within our state. So I think the answer is we want to use all of the above, and they have different roles in our decision-making.
Thank you. Karen, what about you? How has Pitkin County been looking as far as COVID cases, both from the start and today? And what does that look like for your hospitals? Okay, while Karen's working on her audio quality, we're gonna speak with John Douglas from Tri-County. John, what has this been looking like in Tri-County for you?
Sure. Can you hear me? Am I fuzzy?
You're good.
Good. Okay. So Tri-County, Adams, Arapahoe, and Douglas County is about a quarter of the state. So not surprisingly, the trends that Dr. Samet showed are trends that we're seeing in our counties as well. We had our sort of our low point in early June. It's been up since then. We've seen, some sawtoothing, but I'd say generally it's continued to go up. Now we track on cases because those are probably the most robust early indicator of what's happening with transmission. We do care about the sicker events, hospitalizations and deaths. And at least so far, we haven't seen those rise, which is, well, it's obviously good news. And I would say that's at least in part, if not in large part, due to the fact that it's the younger folks that are getting infected. I do want to point out that not getting hospitalized or dying doesn't mean you do great. The CDC put out a report, I think Friday or Saturday, that noted that about a third of the people who were outpatients, not sick enough to hospitalized, were still feeling poorly after 3 weeks. Now you might say, not a big deal, but a lot of those folks couldn't go back to work. They felt so poorly. So I think that, again, hospitalizations and deaths are really critical, but they're not the full spectrum of illness. The other thing I do want to make a point about, John mentioned schools opening. We do desperately, at least I believe we desperately want to see them open as much as possible. I think that not having schools open has had a huge impact, not only on education, but health. And even if you have not so sick people in the community transmitting infection, it doesn't take many of those infections in schools who have begun to reopen to close them down again. So that's another parameter of importance and why I think case monitoring is really critical.
Thanks, John. Hi, Karen, you're back.
Hey, I hope this works. Is that better? Great. Do you want me to dive in?
Please.
Wonderful. So good morning, everyone. I just wanted to paint a quick scene of Pitkin County because I realize that not everyone might even realize where the county is located. So just for the audience's awareness, we're at the head of the Roaring Fork River Valley, and Aspen is the county seat of the county. And our workforce is really intertwined with Eagle County and Garfield County. So when we think about our case data and what's happening in our community, we really want to look at our whole region and a picture of the whole region. And as people are probably aware, tourism is really a main driver of our economy, both in the winter and in the summer. Our census for Pitkin County is about 18,000 people, but right now we're estimating that we have about 39 to 42,000 people in our community. So that really plays a role in how we think about our data and how we think about the strategies that we employ to try to manage disease transmission. So we just baseline data this is as of last night, we've had 153 cases, and our positivity rate is ranging between 7 and 9% within the last week or so. And we have had 2 deaths in Pitkin County since the start of the pandemic. And we have a number of different indicators that we really do try to monitor. So as Dean Samet mentioned and Dr. Douglas mentioned, you know, we don't just look at one indicator to really determine what's happening in our community. We want to look at a number of different indicators because they all tell us a little bit different information. So we look at disease burden, which includes cases at 14-day rolling case count, our positivity rate. We look at our healthcare system capacity. So that includes inpatient hospitalizations, average daily visits, essential workers out of the hospital system with COVID-19. And then finally, our disease control measures. So what's our testing capacity? What's our timely case investigation? Can we get through contact tracing and disease investigation within 24 hours, and then our community spread. So how many cases can we really not track back to its original source? And we look at our neighboring community spread in light of, you know, our interconnectedness with Eagle and Garfield County and what's going on there. So with all of that, really looking at, you know, hospital data as lag data. The other data that we really want to pick up on first are those case counts and our positivity rate happening. What our testing capacity is, sort of that forefront data that we can really use as ways to analyze what's happening. And we've created like a coronameter alert system, looking at high, red is very high risk, orange is high risk, yellow is moderate, and blue is low. And right now our community is in a yellow moving to orange phase. So we're really looking at moderate to higher risk. And then I'm looking at Eagle and Garfield County. They're actually both in a little bit higher range of looking at higher risk right now, not high risk, but higher risk. So we're really trying to track what's happening again across the region and using that to inform our practices that we're implementing.
Great, thank you. Let me build on that testing comment because we had a couple questions from Roseanne and others in our chat about testing. An earlier question was around, you know, the speed of testing and getting test results back quickly, right? So what does that look like? I'm looking to John Samet to start, but also others on this. And then also, kind of if someone does get a test and they get results back, particularly if they didn't have symptoms and maybe they did or didn't have COVID-19, depending on the test that they have, including antibody tests, which is, I know, complicated. does that test, does someone getting tested, does that help their behavior change, right? Like, what are they supposed to do with those results? I'm looking, Dean Samet, will you start with that? And then let me go to Karen and John to follow up with additional thoughts.
I'll just comment briefly. And of course, early on, we talked about testing in this series. And I think everyone knows who's been following the story that we're just not getting the results back fast enough for the public health purposes. And of course, if we want to do contact tracing effectively, we need the results back right away. So I think I would turn to John and Karen for those perspectives on how quickly they're able to get the results back and the potential barrier to contact tracing, as that becomes really an essential strategy for the long run and one we're gearing up to implement.
Sure, I'll take a crack at that. The testing issue is enormous. It's probably the single biggest problem we face in terms of trying to manage the epidemic right now. I mean, I believe in masks, I promote them, but getting good, rapid turnaround testing is absolutely critical. Admiral Giroir, who's the head of the National Testing Task Force, was in NPR this morning. He wants to get test results back down to 24 hours or even less with rapid. I'll tell you that in the metro area right now, we're seeing tests that are averaging between 5 and 10 days, and we're seeing some come back as late as 15 days. It's almost worthless, really, to have a test that comes back that late. A recent Dutch study suggested if you can't identify people for contact tracing within 3 days of the time of the test, that the contact tracing value just begins to plummet dramatically because folks are either getting sick on their own or whatever value of isolation they would have just goes down the tube. I'm sure this audience, especially those of you who've been in all 12 sessions, know the difference in isolation and quarantine. But if you're infected, you go into isolation to try to prevent other people from becoming exposed. If you're exposed but not affected, you go into quarantine, where you try to stay away from other people, not because you're sick, but if you do get sick, you don't want to expose them. And when we can't identify people early for quarantine, it's really an enormous challenge. We really hope it gets better. I know the governor has committed to taking steps to improve that. We really appreciate his leadership in that area. I think, as everybody is aware, we're part of a global supply chain of about 18 different things that you need to do test: kits, machines, pipettes, protective equipment, et cetera, et cetera. And if India and Brazil or Texas and Florida are competing for those items, Colorado can see delays.
Add that we're seeing the same turnaround times here in Pitkin County. I think what's evolved and changed a little bit is that we've had a ability, there's new kinds of PCR tests coming out. And so we do have a accessibility to a rapid format here in Pitkin County using a Cepheid testing kit, and then we also are using saliva. So we see a faster turnaround time with our saliva testing, but for the normal oral pharyngeal testing, swabbing testing, it's definitely slow. And as Dr. Douglas mentioned, if it's so slow, it's not useful for us from a public health standpoint to continue with that disease investigation. So we have created a regional testing strategy for Eagle, Garfield, and Pitkin, and really prioritizing testing for a purpose. And so we are back to really looking at symptomatic folks, people who have direct contact and high risk. So that really is our framework right now, and don't have a lot of capability to really push other kinds of testing strategies, i.e. for asymptomatic folks, just because we know that test turnaround time is slow, and we have to really prioritize populations to get them into our disease investigation process.
Aaron, let me go back to you. So Pitkin County's population is often very fluid in the summer with tourists and increasing. What are some of your data, what it looks like to the local population, and how do tourists play into that, particularly those who are coming from hot spots?
Yeah, so this is it's actually a little bit of complicated data to test out. The way that the public health system works is that we, from a public health standpoint, really are the ones that are tracking our resident population. So we're looking at folks that to have tested positive for COVID-19 illness, get put into the state database, and we then do the case investigation for those folks. If someone is from outside of the county or outside of the state, they will be, the investigation will be pushed to that place of residence. So when we look at the data, we are able to track a little bit of folks that are testing positive for COVID-19 illness that are not of our residency. However, we don't do the full case investigation and follow up with those folks. So on a data front, we're still working really through the levels of detail for this. But what we do know right now is that we've been looking at the theoretical risk exposure to COVID-19 from commuters, tourists, and visitors, depending on their origin. And right now, on June 25th, when we did this analysis, the risk exposure was 23% from Pitkin County residents, and then Garfield County residents was 20, and folks from Texas was about 10. We just did this analysis again last week, and on July 23rd, Texas was 21%. The rest of the US was 14%, and Pitkin County was 14%. So it just shows the impact of visitors and how we can sort of look at that and again, adjust our strategies and our messaging for visitors as well, so they're aware of what we're doing in our community to prevent disease transmission.
I'm seeing some nods here. So Dean Samet, could you talk a little bit about how, mobility data and understanding where people are coming from? We were talking just a little bit about that before we got started. I'm wondering if you could share some thoughts with the audience.
So we've used the mobility data to understand the impact of various measures. Are they working? And to understand where people are mixing them. And clearly we've focused in on the influx of visitors to the state. That is important. As bars and restaurants reopened, we looked at who was there. We were able to gain some insights by age. And those data are useful for thinking about targeting strategies and what needs to be done. And for example, the data showed that there were individuals of cell phones in restaurants, bars going on up till 2 in the morning, which is the time when food is likely not being served, and perhaps with the encouragement of late night and alcohol, people were not as physically distanced as they should be. So I think these data provide tracking, monitoring, and can highlight points where interventions may help. Okay.
Karen, can I add something to that? Dean Samet's team, he's being modest, has also done some fantastic work looking at mobility across counties. And we don't just sit in our own county and live and work and play. We move to lots of different places. Not just Texans coming here, but people in Adams County working in Denver, or vice versa, this sort of thing. And that's been extraordinarily important when we think about policies. That to do a masking mandate, and we've had a lot of experience at Tri-County in the last couple of weeks with that, for a single county when people move around is just incredibly short-sighted. So that's why I think that although the governor likes a matrix of both local and statewide policies, John's data has really helped us understand that we're one economy in some ways. We're clearly one healthcare system. If you get sick in Pitkin and that hospital starts to get overwhelmed, the ICUs you're likely to go to are going to be in the metro area. And then frankly, when we shop and work and travel, we're doing so in an area that doesn't respect jurisdictional boundaries.
Let's build on that, if that's okay, John and others. The idea of local versus state versus even, at the federal level. There's lots of different, like you said, there's even a matrix approach to how you make policy, how you make decisions, data that comes in at all these different data points. What has been valuable to you and yourself as you've been looking about this, as far as coordination across counties within the state, as well as where has there been lacking that you think would be helpful as you think about how do you make decisions for your local communities? Let me punt this back to John Douglas, and then we'll go on to some others and some thoughts.
So I think one of the successes that I've experienced as a local public health director has in fact been regional collaboration with other public health entities. We have something in the metro area, just a little bit like what Karen described for her neighbors in Western Colorado. We call ourselves the Metro Denver Partnership for Health. It's a bunch of, it's the counties in the metro area that we've been working quite closely together with in terms of analytics. Dr. Samet has sort of comes and visits us frequently and gives us his modeling updates in terms of policies, in terms of measurements, in terms of testing priorities. Karen mentioned testing for a purpose. We're really concerned about the testing situation. Lots of schools have, I think, really good plans for testing. I'm worried, well, especially the big universities, that may overwhelm the testing system even more. And so that kind of collaboration, I think, has been really useful. We've tried to message collaboratively as well. I think one of the things we've seen in this pandemic is just how much messaging, consistent messaging, or frankly, sadly, the lack of consistent messaging matters. And although I would have liked to have seen more consistent messaging nationally, I still think there's time to get there. I think that's been a huge detriment in our fighting the pandemic. I think we've been able to stay fairly much on message in Colorado, in large part because of the sort of collaborative efforts that we've been able to undertake.
Karen, would you like to build on what you've been seeing here across different levels of decision-making and collaboration?
And I would echo what Dr. Douglas has said. And we've had our own public health order in place actually since March 12th. So we were one of the first counties to put a public health order, and it was 1 page, and it limited group size to 50 people. And I think back to that day and think about, now our public health order is 30 pages or so, I'm not sure. We have mimicked the state public health order at times, and we've had probably more restrictions in the state public health order mostly throughout the pandemic. And I'm really just trying to have a localized approach to what we recognize, especially with our unique economy in Pitkin County. But with that, I do think the more that we can be at a federal or state level and sync together those are the most successful strategies. So when Governor Polis put the statewide mask order across the state, I think that just gave us all the power. Even though we had our own mask order before that, it just gave every community the power to line up with that. As we look at a statewide testing strategy or a statewide containment strategy, all of these are helpful. Every community has different levels of resources to go into fighting the pandemic. And so, the more we are, I think, aligned across the state and have similar policies across the state, the easier it is for local communities and local health directors and local health departments to really be able to sync up and to be able to fulfill those, because we know that there are politics involved in policy. And so we want to be able to support our all of our whole state to be able to fulfill different policy initiatives so that we have a blanket approach across the state. So I really advocate for any kind of statewide strategies. I think it's going to help us in the long run for sure.
Great. I would like to wrap up with one final question. I appreciate all of your all's time today. We could probably talk for another hour or so, but you're both all three of you are very busy people. So maybe if I could have each of you speak to thinking out over the next month or two, next couple months. There's a lot that's happening. I think there's still a lot of uncertainty about schools. Maybe what is one hope that you hope to see happening over the next couple months, and one challenge that you're looking to face? Looking around to see if someone wants to nod and take this first for me. How about Dean Samet? John, would you start with that, please? And then we'll turn to our other two guests.
Well, I was hoping to hear from John and Karen your tough question. I think you captured an awful lot in that question, because a lot's going to happen in the next couple of months. And I think, just to name a few, schools, I saw some comments on the universities opening, and of course, cold weather brings us back indoors, where we'll be less distance at times. So I think we know that the challenges lie ahead. I think the big question to me is, how do we stay on top of them? And our data system's going to sort of provide us the early warnings that we need. I think both John and Karen spoke to the critical need for having timely test results coming back so that we can implement contact tracing. And there's been a lot of discussion about contact tracing and coordination and collaboration across the state. A new data system, I think, is coming in to help, but I think we've got to stay on top of things and look at leading indicators and not lagging indicators.
Great comment. John Douglas, take this next, and then Karen, wrap us up.
Gosh, great question. What do I look forward to and what are the challenges? I mean, I think schools will present challenges, as I said earlier. I really want to see them get going as much as possible. I think schools, to me, is a metaphor for the kind of balance we want to achieve. I've been watching the chat. Some of the folks in the chat are saying what I hear in my communities. Hey, you guys in public health, you're shutting everybody down. All you care about is COVID. Let me say unequivocally, that's not what we care about. We care about health across society. And I would note that when COVID has not been effectively addressed, look at Texas, Florida, Arizona, the economy does not do very well. So what we're trying to achieve is a fine-tuned balance. I am, because I used to do vaccine research, particularly interested and biased toward vaccines as being a potential solution. It's worth noting that the first phase 3 vaccine trial, one of the top 4 or 5 agents is going to begin phase 3 enrollment today. That includes the Anschutz campus. They'll be enrolling people into this vaccine trial. Early data published in the New England Journal of Medicine about 3 weeks ago looks really very encouraging in terms of immunity. And so I'm hopeful about that, but I don't want to take it for granted. We've got a healthy anti-vax or vaccine hesitant movement in this country, and I suspect that will probably play out with the new COVID vaccine. So I think that if we get a good vaccine, I think that careful messaging and careful attention to public trust in what people like Dr. Samet or Karen or I'm trying to say is going to be a key ingredient as we take various tools we've got to move forward and try to manage the pandemic.
I'd just like to make the statement that, public health is really the route to social and economic recovery. The more we can get right on the public health front, the faster we will get to that space. And Dr. Douglas alluded to this, but as public health professionals, we really recognize that the determinants of health play a role in someone's health outcome, and that includes everything from access to great education, to access to healthy food, to access to employment. So we look at this a little bit more broad than just trying to control the spread of SARS-CoV-2 throughout our community, but we also know that if someone dies of SARS-CoV-2, COVID-19 illness, they don't have the opportunity to come back. If someone loses their job, we recognize that that is a significant hardship for people, but hopefully we have systems in place that allow them to get a new job or have some supports economically until that happens. So, it's not an either or, it's really a comprehensive look at all of the things that we're doing. But with that, it's very hard. It's a very difficult situation for everyone, I know. And I have I thought, Kristen, your quote at the very beginning of think critically and act empathetically is really so powerful, because that really is where we need to be as a community and as public health officials, to have real understanding of the hardships people are going through. This is not easy. These are not easy decisions. These are not easy places for anyone to be in our communities. And so I just really want to recognize that as a closing statement, that we, when we think about schools, the balance of opening schools in regard to we want to make sure that our community transmission in Pitkin County is low enough that schools can operate in the way that provides the best learning for kiddos. So we have a responsibility as a community to ensure that that happens. And that really is our goal right now, and to have a successful winter season, because that's important for employers and employees of our community as well.
Thank you. Well said by all three of you. Thank you for showing up today and for spending time with us, sharing your expertise, sharing your perspectives. I'm very grateful and thankful for the time that you've given me and our audience today. So thank you very much, Karen. Thank you, John Douglas, and thank you, John Samet, very much for the time. There's a lot of behind the scenes pre-prep too that goes into just this morning's show. So we know you're very busy. So thank you all for tuning in today. You had amazing questions and thoughts throughout. As you know, we cannot get to all of them. We recognize that, but we do see them and read them. So thank you for participating as an audience today too. I want to take a moment just real quickly before we sign off here and give a special recognition and thanks to my dear colleague, Alyssa Carlson, who's been your kind of welcome introducing voice that you hear behind the scenes if you tune in a few minutes early, asking where you're tuning in from, setting us up. She's been an invaluable colleague with us at the museum, and I'm super excited to say that she's headed off to graduate school here. This is her last week with the museum, and so we're going to miss her dearly, especially helping with this series. She's been very instrumental. If you've missed any of our previous episodes, I know there's a number of you who've been here for all 12, which is quite impressive. But we have written recaps and video recordings on every episode that we've done. I recommend just go to institute.dmns.org. There's a nice landing page there for all COVID-19. You can go back and read through some of the transcripts. I think it would be interesting to look at kind of where we were back in April when we started this series to looking how we've evolved now. We've got a lot of exciting episodes coming up for you. We'll keep you posted. If you don't receive our emails already, sign up for our mailing list. That's the most surefire way to make sure you get those announcements. You can follow us on Twitter. The Institute is at Institute Cy Paul. You can follow the museum at Denver Museum NS. And our colleagues at the School of Public Health, you can follow them on Twitter at Colorado SPH. A huge thank you to all of my guests today for your time, and look forward to our follow-up thank you note where you'll see the recording and written recap about what was talked today. So thank you for tuning in, and I hope you enjoy the rest of your week.